Welcome back, and we have Dr. Wynn with us today, and she is the medical director of Hoag Advanced Endoscopy Center, and I'd like to welcome you today. Our subject is, well, acid reflux, referred to as GERD, and the treatments that go along with it, right?
That's correct.
All right.
Good morning.
Good morning. Welcome. So, in general, tell us about acid reflux. You know, some of us get that on occasion just because of whatever it might be, what we eat,
Sure.
what we, it can be many different things. But obviously what you're talking about is something that's a little more chronic, heartburn, what people refer to, am I right?
Yeah, there's many different terms. Some patients have the typical heartburn. They feel the food coming back up, and that's the reflux.
Right.
We all reflux, so we all have a little bit of heartburn on a daily basis.
Yeah.
But it's more the chronic condition and the frequent symptoms that define the disease, which is gastroesophageal reflux disease, or what we call GERD.
Right.
So yes, we all reflux a little bit depending on the meals that we eat, the times that we eat, how much we eat.
Yeah.
Yes.
Now, obviously for somebody that gets that on occasion, you have the typical over-the-counter things that can help out for you, the little tablets, the Tums and things like that.
Sure.
Then there's the ones that are a little bit more something that people might take before a meal. Am I right? Like,
yes.
I forget the name of it, Pepsid, something like that?
Sure.
Yeah,
so
I don't know if I said that right, but
right,
people
correct.
will often, who get that a little bit more on a chronic basis, sort of take preventative medicine, right?
Correct. So medications, you have many choices for anti-acid medication.
Mm-hmm.
So the anti-acid medication can be very simple, as needed medication, like you just said, like the Tums and Maalox and Mylanta. The next line of medication is the H2 blocker, which is what you mentioned, the Tagamet, Pepsid.
Okay.
So those medications, usually you take it on a regular basis. You take it every 8 hours and not as needed. And then the next line of medications, what we know is the PPI, which is proton pump inhibitor. They tend to be, they are stronger, and you take it regularly, and you take it twice a day, and you take it half an hour before a meal. But all these medications are anti-acid medication.
Okay.
So you may still reflux, but you don't have that burning. So you may still have the regurgitation, but not the burning associated with it.
So tell us about some of the treatments that are available.
If their symptoms don't improve, or if they have ongoing symptoms despite the medications, then they'll present to the doctors, and they can talk about the options for therapy.
Right. One of the other concerns that people have are, and this happens frequently, I know, with older folks, that they may not have the acid reflux all the time, but they eat their meal, and then later on at night they go to bed and they lay down, and they just, that's when it occurs for them, or they feel that. And I'm wondering if that's something that's normal. Does it come with age, or there are all different reasons behind it?
Yeah, I think there are lifestyle modification that you can do before you can talk about medical therapy. So the lifestyle modification are smaller meals, avoiding certain foods that bring on the reflux symptoms.
Do certain foods, I guess what I'm asking, there's always that, I've heard there's truth to this and there's misconceptions about like spicy foods and things like that. And I've heard, in reality it has to do with the person. I may eat something where, my wife may eat the same thing and it's going to affect her, where I can eat whatever. It's different for each person.
For sure. So when we talk about lifestyle modification for reflux or GERD, certain foods like alcohol and cigarettes and chocolates and mints and tomatoes, those things are going to increase reflux symptoms. But if we avoid everything...
I've heard about tomatoes before. I know my mom, who, she passed away a few years ago, but tomatoes used to affect her. Raw tomatoes, if they were cooked, not a problem.
Yeah, so if you avoid everything that's good in life, then there's really no life, right? So we can avoid all those all those foods that bring on the reflux symptoms, and then we can take the medications And if the medications don't work, then we can talk about interventions like
Yes.
surgery or
Yeah.
endoscopic therapy.
And when you get to that point, some of the advanced treatments, is that something that a long-term treatment, meaning they go in, they get this treatment, and they're good to go for many years? Do they have to come back every 6 months, a year?
Yeah, so our treatment for GERD is a one-time therapy. You can talk
interesting.
about surgical therapy or endoscopic therapy, which is not a surgical technique. Right now we have endoscopic technique or therapy that avoids surgery, and it's called TIF, or
Okay.
transoral incisionless fundoplication. So the transoral technique is
Easy for you to say.
that's right, through the stomach, and incisionless, which is without surgery, no
Yeah.
incisions. And the fundoplication means we wrap the stomach around the bottom part of the esophagus to prevent reflux. So the advantages of endoscopic therapy over surgical therapy, the traditional surgical therapy, have been associated with patients having problems swallowing or being able to burp or pass some of the air.
Okay.
So the endoscopic technique, the great thing with that is we do not have the associated complication of patient having difficulty with swallowing.
Okay.
And also it's great because there's no incision and there's no surgery.
Does the reflux, when we're talking about this level, does it occur where the esophagus hits the stomach? Is that where the sticking point is? Kind of things get clogged up there, for lack of a better term?
Yeah, so when you swallow food, it goes through the esophagus, and then there's a muscle at the bottom of the esophagus. And that sphincter is always closed. When you swallow, the food goes through, and the sphincter opens, and it goes into your stomach.
Right.
In patients with reflux, intermittently that muscle will open up and the food comes back up.
Okay.
So there is a defect in that valve, that muscle. Also, a hernia, which some of us have heard of, a hiatal hernia, where part of the stomach is up above the level of the diaphragm into the chest. And that is a mechanism associated with reflux. So the hernia, the valve, sometimes it's a little loose. So there are different mechanisms that go into increasing heartburn and reflux in patients.
Okay. So if people get to that level, or they get to a certain amount of problems with this, they're noticing more and more, the first step is see your primary care person and have them evaluate that and see if they need to take another step, right?
Yeah, I think if the symptoms are refractory and patients are on medications for a long time, it doesn't work,
Yeah.
or they have breakthrough symptoms, meaning they've been on medications for a long time and they have a change in the symptom. A lot of patients come in and they've been on this PPI drug for 10 years. And they read on the internet and they say, oh my gosh, there's so many different side effects associated with the PPI, so they want to get off the medication. And the other fear is the development of esophageal cancer after many years of reflux.
Oh,
So,
okay.
Yeah. So I think we want to take a look at the patient if they've had ongoing symptoms, something different. Maybe they're having problems swallowing, they're having some weight loss, or refractory symptoms. Patients who are at higher risk for esophageal cancer are male Caucasians. So there is a subgroup of patients that we would worry more, and we would do more investigation to see, is there pre-cancer, is there cancer, is there stricture that we need to assess. So heartburn can be very simple, very benign, but it can cause a significant problem. And we have had and seen a rising incidence of esophageal cancer, much greater than lung cancer, melanoma, other cancers. So that's our fear, and this is where we can make a difference. We can treat this condition, get patients off their PPI, increase their quality of life, and then also possibly decrease the incidence of cancer development.
All right, very good. Well, I appreciate you coming by and giving us some information. And if you'd like more information, you can go to hoag.org/TIF and find out more about there. And if you think that maybe you're suffering a little too much from this type of thing, look into maybe taking the next step. Thank you very much, Doctor.
Thank you.
You take care. We'll be right back.